Did you?
like before, but like quick.
Review. No, not really. It's like an in-depth thing, right? When I told you guys to go home, no penalty, refresh my mind. What did I say?
I'm sorry, I didn't hear you. You said, oh,
Of reading.
What did I say?
You could stay to do 40 more minutes of reading, or if we could do it on our own, then we could go.
So what I'm gathering is,
If we drop the ball, can we start on chapter 25 and make everybody just do it on their own?
no, all I want, wrong
They
fucking
just
bag.
messing with you, girl, they did the reading.
What?
Their veins and all the stents
So I suppose my question is,
and triple A.
did anybody go home and do 40 minutes? Which would have just closed out the chapter.
40 minutes.
I cannot lie. I went home.
No, wait, home to
Yes, I just told you we did that already.
Long days.
All right,
I just
so
mentioned that it's in the latter part. The CCAT, the bypass, the types of the bypass.
that's like 2 slides.
Varicose veins, triple A, aortic, abdominal.
So I don't have to single you out.
I
I don't have to single you out.
No, but I'm just saying, I'm pretty sure everybody else is playing with you.
For those that did do it and understood it, Jasmine, you're free to go.
Oh, say less.
I'm just joking, I did it. I was hanging out.
Wait, I got a question.
I did mine.
I'm sorry,
A review is different.
No, like even if we went through it like before.
So here's the thing, if you feel like prior to lecture, you and you don't think lecture will help you,
Oh, no, I think you're right.
you are free to go.
I'm gonna
Because if you think about it, what the hell is this?
Yeah,
Oh,
I
it
do
is
glance
new.
over at that every now and then.
I was like-
It's been catching my eye.
I did not see that
Check
at
your
all.
Canvas messages. Doesn't everybody get an alert? Like, I get an alert 18 times a day.
It comes to
I get an alert when you guys upload stuff to other classes.
Oh, wow.
Yeah, like, I get alerts on that. I'm like, wait, is this my class or somebody else's class? Yeah. All right, so, Jazz, thank you so much. And I hope you have an amazing week.
Oh, thanks, I have med-pass this week.
Oh, well, enjoy MedPass. Who is MedPass?
I'm doing days. It's his career, but I have to do a presentation and everything. So.
Ooh, they make days.
Bye. Day school is the worst school.
They do a lot of day school.
You didn't do it? You know what I will say? I read it ahead. Oh, I don't like
We getting punished.
But I just also appreciate the honesty, right? Like, what phone number are you on? Just to say like somebody didn't die in the family. I don't know, right? But, all right, so let's hit it. PVD, does anybody know what PVD is? Peripheral arterial disease. Yeah, I can read it. Tell me where it is.
The leg.
Yes. What happens?
No hair. Pain.
Right. Yes, 100%. Girl.
71. Thank you.
81.
71. Yeah. So we have 2 different types. We have PAD, we have PVD, arterial and vein, right? The only real difference is how they are going to have access to check for blockages and if they can, let's say, do replacements. So a venogram is actually a lot harder than an angiogram. So The venogram, which is gonna be checking the veins, right? It's because the veins are so much smaller that it is, I don't know how to explain it. You have to be so much more particular because you don't want to actually go through the vein, right? As opposed to arteries, which are a little bit thicker. So, let's talk blood clots. Embolists are arterial clots. Can you guys give me some blood clots, some blood clots? You guys Eliquis, warfarin is actually on its way out. Warfarin and Coumadin are on their way out. It's because they have to get INRs drawn like every week. Eliquis, yep. That's also a Pixaban. And it's starting to get outdated, believe it or not. But some patients, it's like the only thing that actually works for them.
Yeah.
So you'll still see them in Coumadin clinics.
Does that have to do with the constant retracting of the?
So like, that's kind of the outdated part, is that they have to come like weekly for INRs. But it's the medication as a whole, like the whole kind of formula of it, because now they have like daily injectables, right? They still have the pill form, right, of things, but these daily injectables, like Lovenox, they're kind of taking the hospitals by storm now. So, the whole pathophys behind our embolus is, we know that it's going to be an arterial block, lower and upper extremities, thrombus adheres to the vessel wall, and it can occur from the injury to the arterial wall. So, somebody gets hit by a car, they break their femur, right? You have to watch for clots on that leg every shift, right? Because you already know they're going to be on a blood thinner because they're going to have to get their femur fixed, right? But it's the body that's going to be rushing to heal. That's why we're watching that clot. The body just knows when it has to kick in on overdrive, and usually it's going to be broken bones, broken big bones, I should say. Broken big bones, and sometimes like big muscle tears. So like ACL, MCLs, you'll see a lot of clots in patients like that as well. All right, so tell me the difference between a thrombus and an embolus. One more time? Yeah, so, I always viewed it as, like, your thrombus is like, that's like your core, and then like your branches, so like, I don't know, like Bank of America, right? Like you have corporate office, and then you have like all your little banks everywhere else, like break-offs. So I used to think of like our thrombus as the corporate, the main hub of the blood clot, and then all of our emboli that come off of that as like our little branches that branch off of that. They all come from our thrombi. Causes. Yeah, so blockages, but really it's just gonna all come down to the heart, right? So you could be having a heart attack, it can cause it. Valve disease is gonna cause it. Arrhythmias are gonna cause it. Rheumatic heart disease. But a lot of it is all because of the heart and the way that the heart is not properly functioning. All right, so signs and symptoms. Abrupt onset with acute arterial effusion, chronic arterial insufficiency. That is going to be because your circulation is already altered. Symptoms are always going to depend on what is occluded and how much oxygen and blood is being supplied. And then the whole thing with this whole occlusion is that especially if it's in the feet, gangrene is gonna develop rapidly. So your 6 Ps, pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia. Anybody know what that means? Oh, my stomach.
Something with something very temperature.
Oh, thermia, yeah, I like it. I feel like, let me look at your review. Maybe not. Maybe not.
Oh, you're like cold-blooded.
It was, it's cold-blooded?
It's basically your inability to maintain a stable internal temperature.
Oh. So like hypothermia?
Yeah, it says the medical condition fluctuating body temperature that mimics that of cold-blooded animals. And is caused by an inability to maintain a stable internal temperature.
So it's like somebody who can't go against Antarctica. Right? Well, according to the book, that is. Yes, so it says, assumes the environmental temperature. So it just makes me think that like.
You can have it either.
Or your core, if it's -12. then you're not regulating. Right, because even if, how we should, right? There's decreased movement in the affected extremity. It's pale, melted, without pulses discord. No.
Is that for hypo or
Guys, you stole the test.
What?
Yes.
I lied. No, that's not it.
Yeah, you're close with
Goodbye is.
That's not it. Okay, we're good. Okay. All right, so we know that anticoagulants is always going to be our first intervention, and then there's thrombolytics, thrombectomy, and an embolectomy. All right, peripheral artery disease, PAD. This is just narrowing of the lower extremity arteries. So with the narrowing of the arteries, we know that the blood supply is going to get reduced. If it doesn't have the blood and oxygen, ischemia is going to develop, and then urine has all the effects in the lower extremities. The functional cause from a vasospasm, I can note it in right now. Otherwise, you know the other two. All right, so let me see. We talked about that. Talked about circulation. Results of gangrene, necrosis, ulceration, and tissue could be necessary. Steph, I love that we had that talk about your dad.
I told him that night, he was driving back to, he was in South Carolina, and he was driving back home that night, so I called to check on him, and I was like, by the way, I used your entire, as an example, he was like, oh, he was like, well, if I didn't leave so early, I could have been to school, and I could have just
Right?
I was like, I wish I had your disc still, because they, he got me 30, because they had everything recorded, and he gave me a copy of the disc. Because it's that his surgeon, hired right after that.
Needed it to go further.
Like, I wanted to have a copy, and I was like, I didn't think it was further. Yeah. I told him, I was like, I used you as an example for the whole night.
That's it.
But he's had pretty much all of these, like muscle cramping, and he's at risk of amputation. He has no hair on his legs.
I'm looking to see if or what. Yeah, EKGs, yeah. Like, yeah, it's like EKGs. All right, so this is the signs and symptoms of peripheral arterial disease. These are also signs and symptoms. These are diagnostic tests. This is the diet, some medications. Some solutions that they would do to try to treat it.
What do they need?
What do you mean?
Like, because I've seen people like, before, so cardio for, they have to do a repeat of their classes. One, yeah, it's a piece.
It's usually when they first start.
Like, before they start the,
No, so Plavix is clopidogrel, right? So you have to get to, when you first start clopidogrel, it's usually a loading dose, and then they have to get you to the therapeutic dose. Once you get to your therapeutic dose, it's usually when they stop testing and then they send you home on that dose. So like, let's say they load you at 50 milligrams and then your PTT gets too high, right? Then they're gonna bring you back down, let's say to 25, and then they're gonna go 25 to 30. But once they get it where your PTT level is like, okay, that's when they're gonna start to climb. Clopidogrel's like another one that you don't really see that often anymore. Trying to think. Because when it comes to Plavix, when you go in for different surgeries, Plavix is an anticoagulant that you can still continue, they won't stop the Plavix. But let's say you take Eliquis or Coumadin. Coumadin you actually have to bridge. So you have to stop and do Volvanax to bridge before they can put you back on. If you're doing like Rivaroxaban, you know, any of those, they'll usually say that 4 doses. But I'm trying to think with Plavix and clopidogrel, like with that family, what another, maybe it's Brilinta? No, because it's good for you guys to know that there's different families of anticoagulants and how some do have to be held, and like how aspirin is different from Eliquis and how that's different from, let me just see if it's, let's see if it's Brilinta. Yeah, it is. So Berlinta is also called Pythagorean. I never like specialized in Latin, so all these words are terrible. But like one is gonna work with, let's say, platelets, another one is gonna work with your red blood cells, right? Some are like blood thinners. So they all, there's like 3 different classes, and that's kind of the difference. Yeah. Plavix, clopidogrel, all of those are platelets. And that's what they're testing, to make sure that they're not, setting the platelet counts completely off the radar. Okay, moving on. Thank you for the good last question.
I wanted to know, because I'm like, I've been getting them lately, and I'm like, what is the difference?
Yeah, so sometimes they're gonna start Plavix. After a procedure, somebody comes in for, let's say, like stenting or something along those lines, they're usually gonna give them, that's usually the go-to. They're gonna start them on Eliquis. With like AFib, they're gonna start them on that. Plavix is one of those that you can actually take with Eliquis, both of them together. But clopidogrel is usually with left-sided heart failure. That's usually where you're gonna see that. Yeah, and it also would depend on if there's an arrhythmia and what the age is. So those are nursing diagnoses. Okay, Raynaud's disease. Does anybody have this, or has anybody ever seen this?
I see it a lot. See it all the time.
Yeah, so Raynaud's, one thing that as nurses we have to remember is if somebody has Raynaud's, we need to put the pulse ox instead of on their face. We have to usually stick it to the ear. It can be when somebody's washing their hands with hot or cold water, when somebody goes out in the cold, when somebody goes out in the heat. Let me see.
I hear I'm driving, it's the worst.
Say again?
When I start driving and it's cold out, my toes go completely numb.
Do they turn colors?
They turn completely white, or they turn like purple black. Like they
Yeah.
look like black.
So,
But my fingers don't do it unless I'm like extremely cold, and then they just will stay white if I like, do like a grip. They'll like stay white and then
oh
they'll
yeah,
never
like
come
if
back.
you're putting,
And then they just won't come back, but they won't turn like this.
for how long?
Yeah, like that, until like I get warm again. But my toes will be like purple like that.
So,
And they go numb.
well, so here's what's going on, right? Why is this opening into like a bigger image? It's vasoconstriction.
Mm-hmm.
So when you think about vasoconstriction, the only way that you're gonna try to reverse it, because it's more of like a phenomenon, is to dilate it, right? So if we know that ice constricts, then depending on what's going on with the body, because again, it's a phenomenon, then we know that heat is gonna release it. So for you, you said it's in the cold weather that, so you'd have to, like what, have a heater at work, those 8-hour packs probably.
It's like extra. It's like extra.
Yeah.
I just deal with it. My toes just go numb all the time.
So I was gonna say, if they're gonna be like pins and needles for the person, they're gonna go completely numb. When they do start to get the feeling back, it's probably a throbbing.
Sometimes, yeah.
Yeah. And I feel like the throbbing is gonna definitely go on when somebody's turning purple as opposed to turning white. So for the white, they can call that blanching. Sometimes that happens, especially like when you're washing your hands. Like if you come out from the snow, you come in, you're washing your hands in hot water, they can blanch. But it's the purple that they really want to focus on because they want to make sure that there's no type of blockage, just to make sure that circulation is active on the area.
It goes away.
It does go away. Oh, I thought somebody said something.
So it does affect women in super cold climates.
And then like, you just kind of feel like.
Yeah, we're good. Everybody, we're
Look at it like that. So it's
good. All right,
the
so,
nerve in my hand are very
so we know, right, if it's constriction, then we want to, we know that's caused by the cold, then we're gonna want these people in work. What else? Of course, depending on how bad it is, if you did end up at a doctor, took pictures, ended up at a doctor, they might give you vasodilators just to take in winter, right?
Only if it bothered me that much.
Fair enough.
Because even the medical surgeon I work for, he wouldn't only give them out if it like really bothered the person that much. And like it stayed purple for that long. Like they don't give them out for long.
No, of course not, but like if,
Yeah.
let's say it stayed that way for 2 days,
Oh, well, yeah, I think
Right.
I'd be like, no, this is.
and you know, like heat doesn't work, you know, like.
Right, then yeah.
100%. So protect your
I
hands,
do
wear
remember
gloves,
those
wear
on
wool
myself.
socks, and decrease stress, or revoke stress again. All right, Berger disease, this is inflammation and thrombosis of small and medium arteries and veins of the hands and feet.
Those are awful.
Unfortunately, they say that this is caused from smoking. So, what else? Intermittent blockation, vein inflammation, numbness, and pale physical cold exposure. And then if they end up with ischemia, it'll be ulcers, gangrene, amputation. No cure, but quit smoking. All right, so aneurysms and like Jazz said, AAAs. So AAAs are a 100% medical emergency. Bulging and ballooning or dilation of a weakened artery wall. Abdominal aortic aneurysm, a AAA, is going to be the most common. A hospital will come to a complete stop if you have somebody coming to the emergency room with a AAA. Just FYI. This person is like The Walking Dead.
Taking time bomb.
Yes, 100%. Yeah, this is like no bueno.
Only when it gets so big though.
Yeah, but I feel like if you're in the emergency room
Oh,
and you already have the symptoms.
One of my dad's friends had a 10 centimeter.
Can you say that again?
10 centimeter.
Before that,
My dad's friend?
my dad's friend. Okay, I thought you said my dead friend. Not gonna be still alive. So my dad's friend is a lot better.
Yeah.
All right, so risk factors. He's still alive?
Yeah. Yes, he is.
All right, we're not gonna, okay. Smoking, trauma, hypertension, arteriosclerosis, these are all gonna be your risk factors for aneurysms. Of course, as you get older, you're gonna be higher risk. So, a dissecting aneurysm, this is also pretty bad. So this is where you have a tear in your artery wall, and then it separates, and then you have to worry about it rupturing. So aneurysms are like never good. So C is going to be your first one. All right, abdominal aortic aneurysm. There's no early symptoms. You're going to have back and flank pain. When they say flank, it's going to be like the same kind of flank pain that pulsating abdominal mass, and then you have to worry about it rupturing. When it ruptures, it's going to be severe pain. They're going to go into shock. Here's your digital test, or your diagnostic test, and your interventions. Diagnoses, your nursing care, varicose veins.
Curvy.
Okay, so varicose veins and spider veins are two different kind of veins. Trying to think. Varicose veins are gonna be a lot more protruding. They're gonna be kind of snake-like and bumpy, definitely purple in color, but they're gonna be super painful. Spider veins are just like this thing that happens over age, and I feel like every woman gets them around the knee area by the use 30s.
Yeah, it's on your kneecap, why?
I don't know why, to be honest, but the majority of women get them around the kneecap, you know, whether it's the side or the back. Yeah.
That's why I got here.
So that's that. So it's a structural defect in the vessel wall.
It doesn't hurt, that's why I said
It
it
could
looks
be
good.
a dilation of the vessel that to accommodate needed that help blood forward, further dilation, and blood cooling. Secondary can be congenital. Contributing factors are prolonged standing pregnancy and obesity. So the worst veins I've ever seen was on a waitress. And I will never forget it. She worked in a diner and her varicose veins looked like you could just pull it right off the leg. They were protruding so bad. And she had like a limp to her. And then I heard another table ask her how long she was working. I think they were asking how long is your shift, but she ended up saying something like 47 years. And I was like, damn, her whole life, like she's been standing, running around. I'm sure she had babies. She wasn't obese though, but I was like, at the time I was bartender, I was like, all right, I'm getting out of this beach.
My mom has it, she got half of these two.
Veins in her calves or the calf
Veins
muscle?
are in her calf, but the calf itself is huge too. Her factor would be prolonged standing for sure.
Got it.
Because she's never been obese, but she did have pregnancy before, but it's definitely
On her feet too long. So you want to keep an eye on your spider veins, calves of America. Dull pain, cramping, edema, heavy feeling in the lower extremities, ulceration, and then disfigurement of the lower extremity. Here are your interventions. So sclerotherapy is like on the rise. You used to have to see a peripheral doctor. Now you go to a med spa. As an RN, like a BSN, you can go to school and learn how to do sclerotherapy. That's it, and it clears it out. Yep. You can do it again. So like, you know they do Botox garden? Yeah. So the people who are doing Botox can also do this as well. Yeah, right. I always wanted to open up an ice cream truck. That's a Botox.
Yeah.
And like, I can choose whatever music I want, right? And just drive around.
Just driving to Deerfield County.
Right? And just pay 15 bucks a unit, you know, and just have fun out, right, with the Botox. I mean, you could even get one of those leather, like, layback chairs. You can also laser compression stockings are really good. So like, that's why when you're nursing, you're on the floor, it's an 8-12, they figure you're gonna be up, that's why compression stockings are gonna be good. Venous insufficiency. So venous insufficiency is damaged, aging valve causing pooling of blood in the lower extremities. Chronic venous insufficiency can lead to venous stasis ulcers. So what ends up happening is the veins rupture, it then leaks the red blood cells into the tissue, and then your hand or leg gets this brown color to it. Super leathery, and it is. So with, I want to see if we're going to go back to venous insufficiency or not.
Even once the edema is gone though, the leather skin stays.
Yeah, like the skin doesn't go back to being soft and
No,
100%.
because like my dad, this is like
Are they brownish or are they purple?
Well, he lives in the south, so he's very tan. But it's like a brownish purple color. But
Yeah.
it's like, it's weird. It's not scaly, it's like shiny almost. And it looks like old leather. At one point, I had it like, it's like old leather, but from not having blood flow.
So the difference with venous and arterial is that venous is gonna have like a very thick skin. Arterial is going to be very thin skin. The other thing I want you guys to know is that venous insufficiency is gonna have pitting edema. Whereas, your arterial, well, the other thing too is like venous is gonna go brownish, sometimes purple, arterial is always gonna be red. Because you're gonna start to notice these discolorations in like people's calves all the way down to their toes. Or like, it'll start at the ankle and then it'll go down to the toes. So just color alone, you'll be able to tell if it's vein or arterial.
What if it's just like super like pale and shiny and hairless and?
It's gonna be arterial. Yeah.
For the arterial, you said red, thin skin and what?
Shiny. And for venous, it's gonna be pitting edema, leathery skin, brown, brownish.
Not going,
Say again?
not going.
So for testing purposes, they're gonna tell you it's brown. When it gets like revascularized, that's when the brown is gonna start to turn purple, because it's gonna be like brown and red. And then once you start to get that purple, it's like, it's starting to get light back a little bit. The other thing too is, for arterial, they're gonna have thick toenails. Super, super thick toenails, arterial. All right, so the goal is for the venous is gonna be decrease the edema, heal the ulcer, compression wraps, elevate the legs, avoid them standing and sitting, walk them, and if there are skin ulcers, then, yeah, you can either do boo, or we can, if it's that bad, then skin wrap it. Here's your diagnoses, interventions, nursing diagnoses. We already talked about the embo and thrombectomies and how they use that as a therapy. Intervention, vascular bypassing grafts. So this is just, the graft itself is going to use the artery or above the occlusion, and then your graft is going to take out your blood vessel and put in the graft itself. Endarterectomy. It's just when they dissect the plaque out. Somebody say it, please.
Endarterectomy?
Sure.
What's that?
I like it. I like it. Yeah, carotid. Your dad had a carotid too, didn't he? Yeah. God. Your dad is like this whole chapter.
He is, that's why I kinda, I know a lot, I've done
Yeah.
a lot.
Tell him, Dad, I got 137 slides on you.
I did, I was like, I literally am reading about your entire medical history.
I'm gonna ace this, guys. I'm gonna ace this. Sit next to her. All right, somebody tell me about angioplasty. We talked about this last week. I showed you guys pictures.
They go in and blow the balloon up.
They do. And what happens if they can't use the balloon?
They go with the stent.
They go with a stent. And that's our next slide. Stents. All right, here are some complications with vascular surgeries. I feel like it all kind of makes sense. Here are your post-op therapeutic interventions. Nursing diagnoses. All right, have you guys heard of lymphedema?
Yes.
And how that's different from, oh my God.
Edema.
Peripheral edema?
No, there's lymph.
Isn't it different from regular edema because it's flowing in the lymph node?
They're both L's, but you might be right. There might be like lymphedema and,
One oozes. Something oozes. It freaks me out.
so one,
It smells really bad.
yeah, gross. I feel like anything that oozes smells more like cheese.
Out their legs.
Yes.
They be
So-
standing there and leave puddles.
Oh, right, and they're just oozing and oozing. It looks like they have little fever
They're
blisters.
just-
So gross. So, something I wanted to tell you guys about lymphedema, which again has no cure, is it is heavy in the Italian culture. I don't know if anybody has ever noticed, if anybody's ever noticed like a true Italian woman, I mean,
The cankles.
yeah, they're still breeding them. So I mean, like, it's still a thing, right? Their waist, literally, you
Their
could
calves
touch.
are this big.
Like, you could go, like middle finger to thumb will touch.
But they could look like.
And
they
then the
could,
next thing you know, they have these hips and these thighs and these cankles and these swollen feet. And it's like huge in the Italian culture, right? Like known as with their like aprons, the apron is supposed to stop at the knee and it like stops like mid shin, right? Because they're only like,
4 foot tall.
I was gonna say, I don't even know if they're 5 foot, right? So that's lymphedema, and because there's no cure, there's nothing that they can do other than the fact of like massaging out the lymph nodes. And that kind of like helps for like the body fluid to kind of not get clogged, let's say, and it travels throughout the body. There's no cure. The only thing that it's gonna do is have them feel a little bit lighter on their feet, because they feel like their legs are trunks, right? Now, if we want to fast forward a little bit more into lymphedema, there's women who, this is mainly women. Men don't really have this that much because they also have much more muscle mass than women have, where their arms and their legs are like trunks, and then they have these really small bodies. So if you guys were to ever, here, let's do it now. I personally also think it's a bit of a phenomenon, but
If you're not that bad.
lymphedema, you're right, thank you. Yep. So,
Yes, lymphedema is what I'm thinking of. That leaks. It smells terrible.
it does, 100%. But see how this leg is like clogged, right? The lymph that is there it's like not able to circulate the fluid the way that it should. So I would say that has like a clogged lymph node somewhere. But the crappy thing about this is that it could either affect one or both. And there are tons of yeah, it can get it can get pretty big.
So Liberian legs.
And here's the sad thing, right? Let's say from the waist up, because like this is like legs and feet, but let's say for the waist up, this could be a normal sized person.
Is it common for people to be overweight with that though? Not always.
Not always. Because it's not necessarily like a diet, like a food.
Right.
right? It's not like what they're eating. It's just like their body, like not processing correctly. Let's see. I hope they don't like just show me somebody that like has it throughout their whole body. This one?
Yeah, that one.
Well, this one has cellulitis.
They get like, when the patients come in, they have like, it'll look like that, but they have like the purple patches or like
Right.
different like scales that are almost like flaky sometimes. You peel off their socks and it just starts snowing.
Yeah.
And I feel like,
100%.
it does. It can either be really sweaty or really dry.
Yeah, the
between.
picture I could have.
I will, see, I want to do like the full body, but I might have to go on like one of those medical sites and like find it there. Oh,
See, that's really scaly.
Legs on the whole body.
okay. So here's this woman, right? This woman, right? But when you look at her feet, they're normal. Right? So she has like normal ankles, normal feet, but she's like, and her hands look pretty normal too. But, right? I feel like that's just so painful.
Every day.
So painful. Okay, so, what else? So this is kind of similar, right? Because the only difference though is for the lymph node here, there's going to be some kind of inflammation or infection. With that, you're going to get your fever, your chill, like your whole infection line of things. But also if it's inflamed, then you're also going to end up with pain. You want to monitor for swelling, skin breakdown, and you want to try to see if you can get them some kind of antibiotic. Okay. The nurse evaluates Mr. Agarwal, 53, as understanding cardiovascular disease, teaching if he lists which of these modifiable risk factors of arterial sclerosis. I can guarantee you will see a question like this. You are correct.
6.
100%. You can also add in there hypercholesterolemia, high cholesterol. The nurse collects data on Mrs. Fields, Cookie, 72 years old. She has angina. Signs and symptoms of angina. Does the nurse focus on that are typically seen in women? 1 is right. 4 is right.
5.
No, it's not 2.
It's not 2.
5 is right.
1, 4,
6.
5, and
Yeah, go ahead and say it a little louder.
1, 4, 5, 6.
Thank you.
2 and 3, we're not gonna pay attention to anymore.
What would the nurse include in the patient's teaching plan for pre-hospital care for an MI?
4.
3, 4.
Yeah, 3 and 4. Oh, I knew there was a question about the 6 Ps. It's not on your test though. Yeah. 6. Yes, girl. 100%, everybody now knows 6.
We're gonna recognize it every
4.
4.
3, 2.
Everything but 2.
And 1.
Everything but 2. Who said it?
Me.
Thank you, Corinne. Mr. Wayne, 62, understanding his education, if he states the classic sign of a abdominal aortic aneurysm is
3.
65-year-old patient is admitted with stable angina. Which of the following symptoms would the patient be expected to report?
2.
2 is correct. Oops, sorry.
4, 5, 6 is wrong.
There you go. 2, 4, 5, 6.
Golden.
Sorry. All right. Can anybody teach me anything about lisinopril?
Yes.
Huh?
Isn't that high blood pressure? Or is
It's
that
an ACE inhibitor.
It is an ACE inhibitor. What's the number 1 side effect of an ACE inhibitor?
A dry cough.
Dry, consistent, constant cough. What is another side effect? We give it so that it does what to blood pressure? Right, if they don't get the dose right, what do we have to worry about?
Hypotension.
Are you allowed to take it if you're pregnant?
No.
Absolutely not.
Okay. Does everybody know the peripheral pulses? Does everybody know where the tibial pulse is?
Distributor.
Huh?
Sun inside.
It is like the inside, where inside on the leg?
Under the
Ankle, calf, foot.
Ankle.
Gonna be the ankle, yeah. Inner ankle.
The thing you hit on the dresser and want to cry for 6 hours.
No, the thing that she used to hit with the razor scooter.
Oh. Or what was that stupid thing they attached to your ankle? You had to kick it back.
Skip-its.
Oh my God! Why
My
would
mom just
Why
put
was
my
that
niece in
ever?
some of those.
Why was that ever created?
How does this happen in class? Like, how do we talk about tibial pulses and now we're on to the skip it?
Well,
Because
now
that thing hits you in that.
Modifiable risk factors for arterial sclerosis.
What happened? Missed it.
Modifiable risk factors for arterial sclerosis.
Stop smoking.
Smoking,
Stop
obesity, high
Cholesterol.
High cholesterol,
Smoke.
smoking,
Heart disease. Oh no, no. My bad.
bad diet leads to,
Heart disease.
Leads
High blood
to
pressure.
high cholesterol.
and,
Fatness.
Plaque buildup.
no, what do you say? Yeah, that's fun. What'd you say?
Fatness. Obesity.
Obesity, thank you. I thought I heard you, but then you said hypertension.
I said many things.
It was rapid fire, which is why I was like, all right, guys, my ADHD. We talked about, last class, we talked about cholesterol numbers. We talked about your happy,
I know
your
overall
HDL, your
cholesterol is
LDL, and your
200.
overall, right?
Yes.
The overall is 200, I think,
130.
yep, that one, but I think
That's your
what-
LDL,
The LDL.
yep.
There's something else that's 132.
Oh yeah, your triglycerides,
Triglycerides.
also 130.
Yes.
Yep. Can somebody tell me what nitro does?
Doesn't it stop
They
the
have
chest
two
pain?
giant.
Okay, can somebody tell me the pathophys of nitro? Just one person. I'm having a hard time listening to 18 of you at the same time.
I'm sorry.
Somebody tell me what it does to the blood vessels.
Dilate.
It does dilate it. What happens when our blood vessels are dilated? What does it do?
It
It
raises
can
it.
deliver
More blood.
oxygen to
Oh,
the heart.
I said that. I'm just saying.
You're right, I didn't hear you. Clinical manifestations of an MI.
Chest.
Typical manifestation.
Arm pain.
Nausea. We're just saying an MI, right?
Shortness of breath. Are we saying things?
So I heard nausea. I heard sweating, which is also diaphoresis. Did anybody say anything? No, tell me what goes on with the heart.
Isn't it
High
like a
blood pressure.
blockage or palpitation?
So there could be an arrhythmia or
A stutter type of thing?
STEMI.
Or
tachycardia.
There you go, that's what I said.
Yeah, a stutter.
you know, the
Yeah. We're not there yet, not there yet. Were you guys ever taught about digoxin?
yeah.
How about digoxin toxicity?
Mhm.
The antidote? Go ahead, Dylan. All right. What does digoxin do?
Digoxin lowers the heart rate.
It does. Thank you, Meredith. And do we know what arrhythmia usually digoxin is given for? Yeah, AFib. So, so if you have somebody who has an elevated heart rate and they're now in AFib, right? Now we know that the SA node isn't working. Because we know the SA node is what fires your P wave. If you don't have a P wave, you're in AFib. Okay, my question to you is, if it decreases the heart rate, what node is that now affecting? 100%. And if your patient is coming in with elevated heart rate and AFib, and they're working off their AV node, which is secondary, tell me what you think their symptoms are gonna be.
Wouldn't it be bradycardia because the heart rate is lower from that?
Before you give digoxin.
Okay.
So like now you know you have an AFib patient with a high tachycardic, right?
Okay.
And they're working off their SA, or their AV node instead of their SA. How do you think they're gonna present to you for you to be like, we're gonna give digoxin? 100% shortness of breath. What else? Who said that?
You did.
Go ahead, Dee. I got one more.
Nausea.
Sweaty.
No nausea, no diaphoresis.
Is that any like anxiety?
It isn't. Huh? No, but thank you, that's it. I like
What did
it.
you just say,
What?
Tracy?
He said dipsam.
Okay.
Nope. Okay, you're gonna be lightheaded. Yeah. So you're gonna be lightheaded. So you're gonna be lightheaded because like your heart, AFib is when your heart is working extra anyways, right? But you're onto that secondary node. It's not able to push the amount of oxygen that we actually need to go around to sustain tachycardia.
Mm-hmm.
So you're gonna start to get lightheaded with it. That's why you're also getting fatigued, right? Like your muscles aren't getting the oxygen that it needs. So FYI on, that's like a digoxin question, just like that. we talked about anticoagulants today. We talked about, what rhythm did I say automatically is gonna go on to an anticoagulant? There was an arrhythmia, and I was like, as soon as we find this arrhythmia there, immediately put on anticoagulants. Who said it?
Me. And somebody back there.
D.
I know, I was gonna say it was back there. Thank you. Now, what did we say was the anticoagulant that we don't stop because, it affects the platelets? Huh? Plavix, yep. Also called clopidogrel. And then we also talked about another one that prevents strokes. This one needs a bridge. If you're gonna stop. Coumadin, what's another word for Coumadin?
Warfarin.
Yes. If it's going to prevent strokes, right? It is technically preventing what from forming? Give me another word.
Thrombus.
Let's go with
Thrombus.
thrombus. Thank you, Ty. Yes, okay.
The thrombus is the appropriate, that's right.
What happened?
No, I'm just trying to remember what you said, because thrombus is the initial thing that happens, that starts to embolize, so.
Exactly. We were talking about the corporation.
Yes,
right?
that's why I said thrombus is the corporate.
Corporate, thank you. All right, so I feel like, Corinne, I feel like you brought this up. All right, somebody is having decreased cerebral perfusion with a slow heart rate. What do we think is, how are they gonna present?
Cerebral perfusion will go fatigued.
Will they be sweaty?
No sweat. What did you say last time?
I said fatigue, tired, fatigue, sluggish.
You said something else. Someone was talking to you.
Well, I said bradycardia, but that's low heart rate, so.
Yeah. I feel like, I thought she said it, but maybe it was the bradycardia that is what I
Yeah.
remember. What was the third thing with the digoxin that I told you guys?
I know better.
Dizziness.
Lightheadedness. They're gonna be lightheaded.
Okay.
Oxygen is at the end.
It's like lack of oxygen, right?
Mhm.
ECGs.
I don't know. Britt, you have an episode of AFib?
Yeah, some people do. You can go in and out.
Okay.
You can get AFib from sneezing.
My sneezes are hard, so I wouldn't be surprised.
Yeah, you can get AFib from the stress, let's say, of a car accident. You can get AFib, like, we had this woman come in, and they were like asking her all these questions, trying to see like what happened or whatever. And they think her AFib was her son played, I don't know, what is it called? Semi-professional baseball? I don't know what they call it, right? Maybe that's what they call it? Minor leagues? Minor league, thank you. And she like went to a game and she said that she like lost her voice and she was like doing all this cheering, right? So the doc was like, I bet you she went into AFib like at this game. Like, it's very spontaneous, but the other thing too is like, as long as, if you catch AFib, because think about our heart as a muscle, right? So like, the sooner you catch AFib, the shorter your heart is in that rhythm, the quicker you can get out of it and stay out of it. So when you pass like that 6, 8, 12 month mark, now it's starting to be muscle memory. So you might get, they might, let's say, do a loading dose, a med dose of Defetilide, which is an antiarrhythmic that is supposed to break you out and put you back in sinus rhythm. That doesn't work. Then they do a cardio version. That works for a week and then you're back in. Now they might want to do an ablation. And then you're back in. They're going to cardio over you again. They're going to take you off to Fetolide. They're going to now try, let's say, Sotalol, right? There's all these different things, but really what it comes down to is the only real cure for you to sustain sinus rhythm again is for you not to have AFib that long. So that's why some people will bounce back and forth.
So can't you have it and like it can go not undetected, but like without episodes for like 12 months? Because some people are on really long-term monitors, right? I think you can go like a year without an episode of AFib, right?
Yeah,
And then
oh yeah,
it can
100%.
come on
And they
and
might
go and
sneeze
come
again
go.
and they're back in it.
Yeah.
Yeah, so we have, which are external, they stick to the chest. I really think they only go up to 30 day at this point. And then they have loop recorders, which are now implants. They're like the size of like a grain of rice. And they implant it, and then you could have that up to 3 years. And you could live, so it runs off battery. And once the battery dies, you can still live with it. You know, all they do is like a topical numbing cream. Slice it, implant it, they'll glue it and send you home. And it's the same thing to get it removed. So some people are like, just leave it. If it's not doing anything, leave it. But those are up to 3 years. And you're right, like, they might not have anything for a year. Like, they might be sinus, last that long, and then it could be a year later, they sneeze, who knows? You know, they could be shoveling snow, right? So instead of having a heart attack, that type of stress now put them into an arrhythmia. But usually a cardio version is just gonna snap you out of it and keep you out of it. Can anybody tell me the electrical impulse conduction of the heart? Just one person. What note initiates? All right, now go.
Pacemaker.
I'm gonna have a hard time, and I'm like, just one person, huh? Like, everybody just wants to shine. Shine, shine, shine. All right, we'll get to that, we'll get to this. Your math questions. No. Desired over have. I think it's desired over have is the second one. Desired over have for both of them. Yeah. Did Dawn teach you guys about diuretics? Mainly, let's say Lasix or furosemide?
Yes.
Okay, so what did she say side effects of diuretics are?
Or the static hypotension.
Yeah, so hypokalemia. So what is the range of potassium? Okay.
Maybe done with just like 2 minutes.
What's the normal heart rate?
6,400.
Okay. And what did you guys say? My vital signs, and my heart rate was 54.
Oh, no.
And at 9 o'clock, you do my vital signs at 7, at 9 o'clock, I have a dig dose. What are you gonna do?
Oh, no.
For heart rates
Less
under
than
60.
60.
Say again?
Hold for heart rates under 60.
You do, but what's the first thing you guys are gonna do?
Recheck your vitals.
Check your vitals.
Recheck my vitals, right? Now, if at 9 o'clock or whatever, hour before or hour after, right, is usually your card. So whatever time you guys get to me to give me that dig dose, you guys have to check my vitals again.
Yes.
If it's under 60 again, you guys have to. All right. Anybody know about it? Okay, cardiac rehab is usually offered to somebody who has a heart attack, MI, that kind of thing. It's like a personal trainer for the heart, let's say. There's a lot of cardio involved. They're just trying to bring back strength of the heart. A lot of times, people will think that cardiac rehab is going to undo the damage.
No. Damage is already done.
Right. So we need to make sure that if patients are being referred, or if you're working at a cardiac rehab, that they understand, like, hey, damage is done. We can't reverse it. But you have to do it with some type of therapeutic communication, right? We're not looking to like kill their spirit. What else? Tell me, if you have a patient that has Raynaud's, tell me some manifestations that, like onset.
Pain.
Oh, wait, maybe, I don't know if I'm, how would we prevent the manifestations of Raynaud's?
Gloves.
Heat, if they did, if they're affected by the cold.
Yep. Are we gonna, I know as nurses, we're always gonna tell people to stop smoking, but does smoking cessation affect Raynaud's? It does.
Because smoking.
Raynaud's and burgers are big smoking things, so we wanna make sure, like, if you're a smoker, if you don't wanna quit, you're fucked. Like, sorry, but if I were you, I would do some kind of cessation.
So it's kind of stupid to say no.
Say again?
I said smoking affects everything, so it's kind of stupid to say
Yeah,
no.
and I know it's like, it's one of those habits that a lot of people have been doing 30, 40, 50, 60 years, right? We were talking about your dad. Like, we were talking about the cheeseburger in hospice, right? Just give him the cigarette, give him the burger, right? But if you're talking about somebody, let's say, who's 40, 50, and they've only been smoking, let's say, 20 years, we're gonna still offer you the sensation, right? Like, we're gonna see if it works. We just want you optimistic to try it, that's all. So we know, like, cool is gonna constrict, warm is gonna, all right. Venous insufficiency. We did this today. Somebody tell me what an expected finding is of venous insufficiency. Go ahead. Say it again.
Edema.
Thank you so much.
Leathery skin.
That's all I cared about.
Okay.
Thank you so much. God bless you. You guys are free to go. Any questions? No? Corinne, what's so funny? Big Cass, I'm sorry, I didn't realize that we're, well, at least you're not waiting, right?
Right.
If you guys have questions, let me know. Otherwise, everybody have a great week.
You too.
It's a long way. What have you been reviewed today, girl? Loving it. I have a question. I thought about it. September 22nd. September 22nd.
I think that it was